Hello, my name is Natalie Gaines. I'm a PGY1 pharmacy resident at Harper University Hospital, and today I'll be speaking on potential complications for Milrinone use in critically ill adults. To begin, I'd like to discuss some background about Milrinone. It's a selective phosphodiesterase inhibitor that targets the PDE3 receptor, ultimately resulting in cardiac ionotropy and lusitropy, while also causing vasodilation. This makes it a valuable pharmacotherapy in the intensive care unit for patients with cardiogenic shock or acute decompensated heart failure. As we consider its use in the intensive care unit, it's important to note that Milrinone is approximately 70% protein bound and about 80% eliminated, mostly unchanged from urine. As a consequence, its serum concentration is elevated when kidney function is compromised. Acute kidney injury is anticipated to occur in up to 60% of patients admitted to the ICU. Additionally, for those with renal replacement therapy, the high protein binding of Milrinone makes it less likely to be dialyzed. There are guidelines that exist for patients with chronic kidney disease and how to adjust, but that is not the same for all disease states. In particular, Milrinone dosing guidelines are not established for patients on renal replacement therapy with kidney failure or with creatinine clearance less than 10 mL per minute. The cause for concern with having an increased Milrinone serum concentration is from previous studies such as OPTIME-CHF and the study by Cox et al. For OPTIME-CHF, this study looked at 949 patients with exacerbations of chronic heart failure and compared use with Milrinone and placebo. Now for this study, we're interested in a post-hoc analysis in which they looked at patients with a GFR between 30 and 60 and compared it to those with normal renal function, and found that for those with poor renal function, there was an increased risk of both mortality and risk of readmission or death within 60 days. Cox et al. Also showed that there was an increased risk of arrhythmia and hypotension in their patients with the poorest kidney function. Therefore, we hypothesized that standard dosing of Milrinone in patients with reduced kidney function would result in more adverse events, such as new onset arrhythmias, cardiac arrests, and incidence of hypotension when compared to patients with good kidney function. To test this hypothesis, we created a retrospective cohort study that examined patients at Harper University Hospital in Detroit, Michigan. We looked at patients between January 2018 through December 2023. Patients were included if they were between 18 to 89 years old, diagnosed with cardiogenic shock, and received continuous IV Milrinone for over 6 hours. Patients were excluded if they were from vulnerable populations, had a hospital admission of less than 24 hours, or received concurrent dobutamine. Our cohorts for kidney function were divided into good, moderate, and poor, correlating with a creatinine clearance greater than 50, 30 to 50, and less than 30 mL per min, respectively. We chose to base this off of the serum creatinine collected on the first day of Milrinone infusion initiation. Our primary endpoint was the incidence of new onset arrhythmias lasting greater than 30 seconds or requiring intervention. Some of our secondary outcomes included hospital and ICU length of stay, number of patients alive and ICU free at 28 days, incidence of code blues while on Milrinone, mortality, and hypotension, which we characterized by vasoactive ionotropic score. This compiles a relative sum of all of the vasopressors and ionotrope that a patient is on. So if they required a larger support, then that would indicate worse hypotension. All of these were analyzed in Excel 2016 and an online statistics platform. Of 461 patients screened, 198 were excluded, mostly because they had insufficient quantities of Milrinone. 263 patients did meet inclusion criteria and were analyzed accordingly. For our baseline, the majority of our participants were male, African American, and had a BMI of about 31. Additionally, the most common comorbidities were hypertension and heart failure, with a median ejection fraction of about 25%. About half of our participants had normal kidney function on admission, with the remaining half having either acute kidney injury or chronic kidney disease. Harper University Hospital also contains a specialized cardiothoracic ICU, and 45% of our participants underwent some kind of cardiac surgery during their admission. This was mostly coronary artery bypass graft, or a valve replacement or repair, or a combination of the two. Additionally, 23% of patients received some kind of mechanical circulatory support, with half of this subset requiring an intra-aortic balloon pump. The median hospital length of stay was 16 days, and the median ICU length of stay was 10 days. 22% of patients did unfortunately end up expiring, with the majority being from cardiac causes. The average Milrinone infusion rate was about 0.25 micrograms per kilograms per minute of Milrinone, amounting to a median of 1,820 milligrams that patients received during their admission, which was, on median, administered for 84 hours continuously. For our primary outcome, there was a significant increase in the incidence of arrhythmia for patients of both our moderate and poor kidney function subgroups. On average, their arrhythmias started 2.2 days after the start of Milrinone, and this was significant with a p-value of 0.00026. Of those who developed an arrhythmia, the majority, 58%, developed atrial fibrillation, with the second most being ventricular tachycardia at 22%. We also examined the incidence of arrhythmia for renal function based on the lowest creatinine clearance on Milrinone, which was significant as well as kidney function on admission. Altogether, this shows that the trend of reduced kidney function does increase the likelihood of risk for arrhythmia with Milrinone. For our secondary outcomes, we found that those who developed arrhythmia were significantly more likely for all of our parameters to have a worse outcome, whether it be longer hospital or ICU length of stay, fewer ICU-free days, a higher incidence of code blue, more incidence of hypertension, or a higher risk for mortality. When looking at the characteristics for those that developed arrhythmia, those that had a higher age and higher BMI were significantly more likely to develop arrhythmia. Patients were also more likely to develop arrhythmia if they received a greater total quantity of Milrinone and were on it for a greater total amount of days. Additionally, those that required more vasopressor support on the same days that they were on Milrinone were more likely to have an arrhythmia. These data lead us to conclude that there is a significantly increased incidence of arrhythmia for patients who are on Milrinone and have moderate or poor kidney function. Additionally, these arrhythmias are likely what contributes to a significantly worse prognosis for the patient, as shown by our statistically significant secondary outcomes that were worse for patients. When we looked at baseline comorbidities, medications, and other factors, they were similar between the kidney function groups, leading us to believe that this is truly from Milrinone as opposed to an underlying variable. Some limitations include that this was conducted at a single center with a retrospective study design, and also that we are a specialty referral hospital with a population that has a higher baseline level of comorbidities. Additionally, kidney failure is an independent risk factor for mortality, and we may in the future try to identify those at higher risk for poor outcomes based on Apache score. Based on these data, we recommend avoiding Milrinone in patients with moderate and poor kidney function. If it is utilized for these patients, we recommend using the lowest infusion rate possible for the shortest duration of time to avoid adverse events. In order to be verified for the general population, this would need to be confirmed in large multi-center studies. I would like to acknowledge the amazing contributions from Drs. Wabi, Gumbleton, Isaacson, and Alreyes that helped make this research possible. Here are my references, and thank you very much for listening. If you have any follow-up questions, please don't hesitate to reach out at my contact information listed here.